Thank you very much. Good morning, everybody. I'm very pleased indeed to be here. These are my conflicts of interest. So, after a brief background, I would like to discuss the third-generation cephalosporin-resistant problem. I will focus on ESBL and with the question of carbapenem or not. The carbapenemase producing enterobacteria issue, which is a very difficult challenge. A more difficult challenge, extensive resistant non-fermenting gram-negative bacilli, and I will very briefly focus on Pseudomonas. And finally, the question of the impact of multi-drug resistance on our daily practice on antibiotics. I like this figure from the recent Matteo paper showing the vicious circle of multi-resistance. You have resistant microorganisms. The consequence is you use broad-spectrum empirical treatment, you increase the incidence of resistant bugs, and you increase inadequate empirical treatment with consequence on mortality due to different infection, especially VAP. This is the distribution of pathogens responsible for ICU-acquired pneumonia in the French network Raisin, and as you can see, gram-negative bacilli account for approximately two-thirds of the cases, either enterobacteria or Pseudomonas. And this is probably the same in most countries. When you talk about multi-resistant in enterobacteria, especially to beta-lactams, is generally the consequence of multiple mechanisms, ESBL plus MC plus permeability or efflux plus sometimes carbapenemase. And the problem is that there is a possible or frequent cross-resistance with aminoglycosides or fluoroquinolone. And it is the same for Pseudomonas with many mechanisms of resistance, but probably, except for some epidemic situation with carbapenemase, the most frequent mechanism of resistance among beta-lactam is a combination of MC and hyperefflux or OPRD. And it's the same for other antibiotics. Finally, to close this first part, this is the incidence of gram-negative resistance in nosocomial infection, especially VAP, in different networks. And as you can see, for E. coli and Klebsiella, the incidence of resistance to cephalosporins vary very widely among networks, and it is the same for resistance to ceftazidime and carbapenem Pseudomonas, and for the same drugs for Acinetobacter baumannii. The second problem is the ESBL issue. And this is again the French network Raisin, showing the dramatic increase in the incidence of third-generation cephalosporins, which is in part explained by ESBL, not many, fortunately, imipenem resistance, and as you can see, resistance to cephalosporins is 50-50 due to ESBL or non-ESBL, which are generally MC. When we look at the results of the meta-analysis, which was conducted by the Falagas, well-known Falagas group, this meta-analysis suggests that either for empirical or definitive treatment, when you use a combination of beta-lactam inhibitors, generally piptase, it's not inferior to carbapenem. However, in my opinion, the issue remains largely open. because of the inoculum effect with peptides, because there are considerable heterogeneity in trials, because the most critically ill patients receive carbapenems, and in these studies there are very few VAP which were included. So the only question, you cannot use peptides if you, as empirical treatment for a VAP. The question is, can you use peptides for definitive therapy according to the MIC? And this is a very classical paper of Retamar showing with bacteremia due to SBL coli, when the source is other than UTI, for example, a pneumonia, the mortality rate increases when the MIC is higher than 2, but as you can see, the number of patients is very, very low. But this is the problem with peptides is confirmed by these Israeli studies showing that for bloodstream infection of non-urinary source caused by ESBL, the mortality risk is much higher if you use piperate tazobactam. And this is the same for cefepime, with a nice correlation between the MIC and mortality. So maybe we have other drugs, and you probably know this recent paper published by Pierre-François Laterre on temocillin in critically ill patients with 6 grams, either with intermittent or continuous infusion. They show that the free-level drug concentration were higher than the MIC, and the cure was obtained in 64% of patients with lower respiratory tract infections, but there were very few ESBL. So the 2 welcome antibiotics for the treatment of ESBL are ceftolozane tazobactam and ceftazidime tazobactam, which are both active on class A, ESBL, and MC. The third point is the CPE issue, which is really a very difficult challenge. And I would like to illustrate that by a very brief case report we had in our department. 33 years woman who lived in Saudi Arabia, who had progressive respiratory failure. She was hospitalized in Jordan with pulmonary fibrosis. Her condition worsened in July. She was intubated and received in Jordan venovenous ECMO, and she developed VAP with positive blood culture, a KPC, Klebsiella pneumonia OXA48, with multi-resistant Acinetobacter and susceptible Pseudomonas. She was treated with meropenem and TG, admitted in our department at the end of August with the same KPC and Pseudomonas. This is a chest X-ray, and this is the susceptibility profile. And as you can see, the strain was resistant to all beta-lactams, including meropenem, intermediate to amikacin, susceptible to TG, resistant to coli, and susceptible to fosfomycin. So, if we look at the algorithm, which was proposed by George Dicos for this patient, the MIC of carbapenem was higher than 4. The strain was intermediate or resistant to aminoglycoside, resistance to colistin, so we have to choose other antibiotic. Why not very, very high dose of amikacin, as it was proposed by our Belgian colleagues? And it could be possible in our patients. The MIC was 16. We could obtain a very, very high level, provided that you use CVV HDF. And don't forget that gentamicin or amikacin can be useful in this paper in ICU patient. When you use gentamicin, the survival is better. Many patients had pneumonia, but as you can see, the peak was quite high and the strain was susceptible. But even for carbapenemas producing strains, the percentage of susceptibility to aminoglycosides is quite good, 40, 50%, and I think this is the good news. Why not using amikacin in aerosol? Quite difficult with this patient with RDS. And it was nicely shown by Charles-Édouard Luit that you have quite low concentrations in the serum, while you have high concentration in the health or trachea. Why not using IV colistin even if the strain is resistant? Because sometimes you can have synergy like that with meropenem or with tigecycline. The problem is you don't know if the synergistic effect is present. Why not using tigecycline in this patient, at least for the Klebsiella? You probably know that at a dose of 50 milligram, tigecycline failed to show non-inferiority in comparison to imipenem in VAP, but maybe when you increase the dose, you double the dose, the result is probably better. Why not using fosfomycin? And the strain in our patient was 12 milligram per liter, which is susceptible under the breakpoint according to UCAST or CLSI. And this is a study which was performed in Spain with ICU patients, multi-extensively drug-resistant KP or Pseudomonas, and they obtained, and it's very important to see that the daily dose was 24 milligram in combination with colistin or tigecycline, and they obtained quite good, not extraordinary, but quite good results, clinical results or microbiological results, with only 4 strains. It's relatively high resistance to fosfomycin, and quite few adverse events. And I think it's important to show this paper, which was the study which was performed by the group of George Druzano, showing that only with the 24 milligram dose per day, you can obtain total eradication of the bacterial population, even strains with higher MIC. So the 12 milligram dose, 16 milligram dose is not appropriate for this patient. And finally, for this patient, why not the very bizarre combination of a double carbapenem, the combination of ertapenem and meropenem, which was proposed by our Greek colleagues. But as you can see, there were a majority of UTI, few bacteremia, however, and few patients in severe sepsis or septic shock. However, they obtained a good clinical and microbiological success with some relapses. So I don't know really what is the efficacy of this combination. What was done for our patient? We used a combination of ceftazidime avibactam, which was obtained for compassionate use because the strain was susceptible, with 24 grams of fosfomycin as continuous infusion, and because the patient had normal renal function, we used 5 doses, high doses of amikacin with very, very high peak doses, no renal replacement therapy, but fortunately no problem of renal failure. And we obtained a very significant decrease in the inoculum, unfortunately with superinfection with a multi-resistant Acinetobacter, which was treated with IV and aerosol coli, and she died at day 30. Lung transplantation was deemed not possible in this patient. And there is not a similar case, but a very well-described case in a recent paper of multi-resistant Klebsiella pneumonia bacteria. She was a 64-year patient with intestinal transplantation. She developed VAP and UTI with this strain. She was treated with Tige, coli, mero, ertapenem, and no success, and she was cured with a combination of Casavi. Again, if we look to the two welcome antibiotics, the two molecules ceftolozane-tazo and ceftazidime-avibactam, and if we look at carbapenemase-producing strains, only ceftazidime-avibactam is active on KPC, not ceftolozane-tazobactam, and ceftazidime-avibactam is better on class D, OXA, and OXA48 strain. As you can see, neither drug are active on class B. You know the metallo-beta-lactamase, the New Delhi strain, and maybe this is a picture of Marc Bonten. There is a project with the combination of Astronam-avibactam to treat patients with metallo-beta-lactamase producing gram-negative. Briefly, the multi-resistant non-fermenting GNB, which is a terribly difficult challenge. You know that the prevalence of ceftazidime-resistant Pseudomonas in Europe is approximately 15–20%, with 5% of strains only susceptible to colistin. And unfortunately, there is no magic bullet. And there are different regimens. We have no time to discuss, and it's a little bit boring. Mono or combination therapy with a regimen based on colistin IV and or aerosol, or based on Astronam with coli, cefepime, ceftazidime coli, phosphomycin. Just two examples. The first one is, as you know, we have learned that if we use very high dose of colistin IV, 9 million per unit after a loading dose, the rate of success is better, the mortality rate is lower. So this is generally for all strains, all multi-resistant strains. And probably, I'm not sure of that, the combination of aerosol therapy and IV colistin is probably better for patients with colistin-only susceptible gram-negative bacteria, especially Pseudomonas. And this is one of different examples of bizarre combination. This is a paper from Hervé Dupont showing the results on very few patients of the combination of Astronam with cefepime for the treatment of nosocomial infection due to multi-drug-resistant strain of Pseudomonas. Why? Because probably the explanation is the fact that Astronam protects cefepime from cephalosporinase, the hyperproduction of cephalosporinase. And they included 13 patients, most with nosocomial pneumonia, high severity score at admission, high CPAS score at inclusion, which decreased to 2 at the end of treatment, 2 weeks treatment, and a pretty good percentage of cure. I don't know if this is really a relevant combination. And to finish this part, I would like to insist to this problem that the best, probably up to now, the best effective drug against Pseudomonas is a combination of ceftolozane-tazobactam, which has in vitro activity and bactericidal rate higher than ceftazidime. And as you can see here, this drug is active on not all, probably half of multi-drug-resistant Pseudomonas, including ceftazidime non-susceptible, meropenem non-susceptible, tazocillin non-susceptible, or strains which are non-susceptible to the 3 drugs. And we are really awaiting the results of these 2 ongoing phase 3 trials in nosocomial pneumonia with the 2 drugs. These are the company, the name of the study, and probably many of you are participating to this study. The same population, a high number of patients. The REPROVE study had just finished recruitment, and the other one is still recruiting. And to finish, just 3 examples of the consequences of multi-drug resistance yes, in red. First, I think that for this patient, you need to measure beta-lactam concentrations and to measure the MIC, and there is a relationship between the PK/PD and the outcome, especially for patients, the more critically ill patients. So I think it's very important. The second point is continuous infusion of beta-lactam, which is conceptually very interesting. But you certainly know the results of the ENZIC study showing the absence of difference, but only 20% of the infections were documented, and there were probably very few, if any, multi-drug resistance. So if it's interesting, it's for this infection. And just before my conclusion, it's the impact of multi-drug resistance on the duration of antibiotic therapy. We do not know. We just know that the rate of recurrence is higher for Pseudomonas when you treat 8 days instead of 15 days. But what about ESBL, MC, and CPA? We don't know, and we hope that we will have some information in ongoing trials. So in conclusion, sorry for the delay, the treatment of VAP caused by multi-resistant GNB is one of the most distressing challenges. Ongoing phase 3 trials probably will bring the response of the efficacy of new molecules, and we have to evaluate the clinical impact on multi-resistant on antibiotic use. Thank you for your attention.